From the Tennessee Department of Labor and Workforce Development, this is Tennessee Workforce Weekly. Here now is Chris Cannon.
Hi everyone and welcome to this edition of Tennessee Workforce Weekly. Today we are on location in Murfreesboro, Rutherford County at the Tennessee Bureau of Workers' Compensation Education Conference. For the last 21 years, the conference has brought together workers' compensation professionals from across the state. There's an expo hall and always a great lineup of speakers. Mark Pugh is one of those speakers, and he'll be talking to attendees about the opioid crisis. Mark, thanks for joining us today.
Thanks for having me.
Give us your background and how you wound up here in Tennessee talking to folks here about the opioid crisis.
Certainly, I've been in work comp for several decades, more than I should probably understand, and I've enjoyed getting to understand and know a lot of people in workers' compensation, including the folks here in Tennessee. I've been engaged in the opioid issue since 2003, one of the first ones that really identified the issue back then, and have been preaching the gospel of trying to find the most appropriate balance of how to manage pain. Sometimes that's opioids, sometimes it's non-opioid prescriptions, and sometimes it's no drugs at all, and that's really what we're going to be talking about today.
Take us back to 2003 and kind of tell us how things have changed since when you first noticed it back then. Flash forward to 2018.
Well, back then it really wasn't a personal issue to so many people. Now it is a very personal issue. When I speak at conferences and other events, I oftentimes ask a simple question. How many of you know someone who has become addicted or dependent upon opioids? And unfortunately, a third to a half the audience typically raises their hand, and about a half of those keep their hands raised when I ask how many of you know someone who has died because of that. Back in 2003, it wasn't a personal issue. It wasn't something that was splashed on the front of USA Today or CBS 60 Minutes or anything like that, but now it's part of our culture and understanding the dangers of opioids. And where we're trying now to get is what is the appropriate balance between the overprescribing of opioids that really started back in the mid-1990s and the appropriate management of pain, because we can't leave these people in a lurch without any kind of management tools whatsoever.
Sure, and really with all the media coverage, it really has become the buzzwords, the opioid crisis. You hear that all the time. Do they still play a role in pain management for people who have serious injuries? They
do, and I published a blog post last year called Appropriate, Not Zero Opioids. So the pendulum has swung, I think, to some degree from overprescribing to doctors not wanting to touch them whatsoever.
Wow, okay.
And unfortunately, what that's doing is sometimes those physicians are not allowing those patients to find alternatives and just dropping them. And so there's a lot of patients now that have been using opioids maybe for function, because really when you look at ODG, which is the guidelines that Tennessee is based on, ODG says that it's based on function and activity. If you can prove objectively that they are receiving function, activity, that the side effects are decreased, that the benefits outweigh the risks, then it makes sense. And so you got to evaluate each individual on an individualized basis. So there is a role for opioids, not nearly what it was starting in the mid-1990s and gravitating to now. So that was overkill, but we're kind of going the opposite direction now. And why I've been preaching the gospel of the biopsychosocial spiritual model, taking into account people and the things that the people can do themselves.
When you speak at the conference, what will the discussion be about? What will folks take away from that?
Well, we're going to talk about the opioid epidemic, but very in a short period of time, because I think everybody understands that. Then we're going to talk about the appropriate use of opioids, when they can be used, and the value of this session is Dr. Jeff Hazelwood. He's a PM&R doctor here in Tennessee, understands pain management very well, is boots on the ground, if you will, helping people trying to figure out how to manage that pain. And so we're going to have just a dialogue. It's not a didactic lecture. That's why we've got two chairs set up in kind of a living room setup. It's not us standing at a podium. It's us talking back and forth.
Sure.
So we're going to talk about the appropriate use of opioids, and we're going to talk about non-opioid prescription drugs, gabapentin, NSAIDs, other drugs that can be used. But we're going to spend most of our time on the biopsychosocial model, alternative treatments, yoga, mindfulness, eating better, sleeping better, cognitive behavioral therapy, a variety of different things, deep diaphragmic breathing. There's not a CPT code from what I'm aware of for deep diaphragmic breathing, but if you've ever been in stressful situations, you understand that deep breath, it really helps kind of get things under control. Lama's approach for childbirth, it's all about deep diaphragmic breathing and dealing with the pain. So why don't we teach that to people to help do that? As far as I know, nobody's ever died from yoga. Maybe the hot yoga where it's 130 degrees, I can
Exactly.
understand that, but I don't, but
So there are different approaches out there, and you'll be discussing those.
absolutely, with a doctor, and obviously from my perspective, what I've seen in the industry, what I see in society, because one of the things I bring to work comp is a bigger perspective than comp. Unfortunately, in comp, we get very myopic, and we tend to think that only if things say workers' compensation in the name is it applicable. Well, the 3-day supply cap in Florida, where you can no longer get a 30-day supply of opioids for the acute pain, it doesn't say comp anywhere in the statute, but has a direct impact on comp because doctors can't prescribe 30-day supply in comp either.
Sure.
So you got to have that broader perspective. So Dr. Hazelwood, boots on the ground, treating patients, trying to figure out individually what they do, and he has that broader perspective. He believes that opioids have a role, but he also believes that other treatments have a role as well.
So an important discussion that will take place here, and I'm sure that people will take a lot away from it. Mark
hope
Pugh,
so.
thank you very much for joining us today.
Thank you.
And thank you for joining us on this edition of Tennessee Workforce Weekly. We'll be back next Monday at 10 a.m. online and on demand. We'll see you then.